labor, fetal monitoring. Talking about the 5 keys of labor. Do they include in your, can anybody look at this week's, do they include like preterm labor, uterine rupture, and cord prolapse too? Those are what have been covered in the past.
This is for Esther.
Yeah.
I don't know if it stops last week, so there's no this week or next week's folder.
Oh, there's not? I was thinking there was some.
There might be a study guide. And see if there's a study guide to upload.
Today?
Tomorrow. Thank God. Yeah. Well, not early in the morning, probably like 11, 10:30.
Okay, let me double check something real quick. That's a lot of information, so if you don't need to know it all, I'd rather not talk about it all, but.
I didn't realize we still had class this week, but then it makes sense because we haven't had class since. But we did.
We have a final next week, so we have a review in the classroom.
I have no idea. Did we have class on Thursday?
You get ATI?
Oh, that's why we didn't have class.
So I think we have class and then isn't there a path 8 Friday?
Okay, so week 12 in her schedule listed hypertension and metabolic disorders of pregnancy. So that's our preeclampsia, our chronic hypertension, our HELP, and diabetes, which I already talked about early in the semester when it was the original schedule, so that should already be recorded. So then last week was supposed to be covering phases of labor, fetal lie, attitude, presentation, so the 5 Ps. Umbilical cord prolapse and uterine rupture, tocolytic therapy, and fetal surveillance, so that's fetal monitoring. And then this week is supposed to cover analgesia and anesthesia used for coping, intrapartum infection and shoulder dystocia, and then postpartum hemorrhage, which we've already talked about. So the big things with, I'll just quickly talk about analgesia and anesthesia. So you guys have all seen epidural anesthesia in labor, correct? So we know we are closely monitoring blood pressures afterwards. If our blood pressure drops, did anybody see their patient's blood pressure drop after an epidural on the floor? No? Okay, so depending on the anesthesiologist that's on, you may be more or less likely to drop their blood pressure, depending on the medication they give them for their bolus medication. We just know this anesthesiologist, it's gonna work real well, the epidural, but it's gonna drop their blood pressure. When the blood pressure drops, the blood flow to the baby drops. So then we have a deceleration in the hurry, which we will talk about fetal monitoring in a minute. So what are we gonna do for low blood pressure? Do you think?
Increase the IV rate.
Yep, increase our IV fluids, exactly. And then there's 2 medications that we can give on the floor. Ephedrine or phenylephrine. I knew somebody was gonna ask that. I gotta write it out. See if I remember how to spell it.
It's to give it the blood pressure drops.
Phenylephrine.
Yeah.
What was the other one? Oh, I definitely
Ephedrine.
Wait, is it the same thing as that?
Ephedrine. So EPHEDRINE, I believe. I'm not the best at spelling off the top of my head. I have to write it out. So big thing, ephedrine is 5 to 10 milligrams. Phenylephrine is 100 micrograms for the dose. And then usually our orders say give the medication and call anesthesia, but usually you do have sorry, I can sit down. Usually you do have a order, a PRN order to give before you call anesthesia, but then you would call. So increase fluids and give a medication if it's low enough. And we're talking, usually it drops like less than 90 over 60 before we're giving medication, depending on what it started with, right? Our preeclamptic patients, if they're running 160s over hundreds, and then we give an epidural, which sometimes we use actually to lower their blood pressure. We're like, hey, your blood pressure's crazy high. Let's see if an epidural would help. And then if it drops to like even 120 over 80, that's a normal for you and I. But for them, their body's used to running at that 160 over 100. So we just kind of have to see if our baby's tolerating it is really what we're looking at. Otherwise, you guys know about spinal and general anesthesia for C-sections. And we know that general anesthesia goes to the baby. That's the one that goes to the baby. So we're getting baby out quickly if we have to do general. Intrapartum infection is going to look a lot like postpartum infection in terms of symptoms. We kind of talked about some of the labor symptoms there. Our group B strep positive moms were really looking for intrapartum infection with them, but prolonged rupture is also going to increase our likelihood of infection. Frequent vaginal cervical exams is going to increase our chance of infection. Temp above 100.4 is still what we're looking at, but usually those moms will spike quite a high temperature, 101, 102. And when you go to check their cervix, they feel hot. Like you're kind of doing an internal temperature, right, when you're checking their cervix. So even if your oral thermometer says, oh, she's only 99, but then you check their cervix and you're like, that is a hot oven. So that we're looking at that, and then our baby gets super tachycardic. So our heart rate gets to be like 160, 170, 180 on our baby because baby is also hot. We're going to treat intrapartum infection just like we treat postpartum infection, IV antibiotics, and then baby will go to the NICU for IV antibiotics as well, usually. Sometimes, depending on how hot they stay, sometimes they'll just draw labs and monitor baby to see if they show any symptoms of infection. What's our baby's symptoms of infection? They usually come out with a high temperature, but what are our symptoms of baby, do you think, being sick? Any idea? Crying, yeah, they can be inconsolable. Low temp actually is worrisome on baby. They're using all that energy to fight that infection, and we know that they aren't very good at regulating their temperature. So they may come out hot, but then later on, if we're looking at infection, we're looking low temp, respiratory distress, hypoglycemia. The baby is trying to, or the baby's getting sick, and that's how they compensate.
Will they come out with erythema?
Hmm?
Will they come out with erythema? Like on the skin? Like rashes on the skin?
So this is like right when they come out, not like
Right
the-
when they come out, they're
okay.
gonna usually come out hot.
Oh.
Like 102, 103. They're gonna be hot because mom was just hot. But if our temperature kind of regulates after delivery, which usually does because they're out of the oven, long term while they're there, the first 24 hours, that's what we're looking at. Low temp, respiratory distress, hypoglycemia. And then shoulder dystocia. We talked about this in my group during our simulation. What's a sign of shoulder dystocia? Do you remember what it's called? The head's coming out and the shoulders get stuck. So what happens to our head?
It's like a turtle.
Yes, a turtle sign. So it comes out and then it goes back in because our shoulders are stuck. What are we gonna do for that? We're gonna do McRoberts, which is pulling the legs further back. We're actually gonna lower the head of the bed completely flat. Open the pelvis as wide as we can. And then what's the charge nurse gonna do if it's still not coming?
Maybe
Where?
Like, go on top of like.
Not on top, where are we going? Where are the shoulders now? I've delivered the head, where are the shoulders now in my body?
Pelvis.
Yes, so suprapubic pressure, just above the pubic bone is where those shoulders are. And we're doing that suprapubic pressure to push those shoulders together so that they fit through the birth canal. And then we talked about postpartum hemorrhage during our simulation. What's our number one priority?
Massage.
Massage in the fundus, right? And then call for your friends. Okay. Does that make sense for week 15 stuff? Brief overview. Okay, so should we go back to week 14 and discuss stages and phases of labor, fetal lie, all that kind of stuff? Okay. So there are 3 stages of labor. Sorry, I wish there was a marker board at the front. So what's the first stage of labor? You know?
Did we learn this? Did we learn this? I don't feel like we learned this.
Okay. Well, let's start at the beginning. Okay. So first stage is our labor stage. So from 0 to 10 centimeters. And this has 3 phases. Oops. We have the latent phase. Active. And
Okay,
transition. So our latent phase is we're kind of just starting to contract, not real uncomfortable. Kind of that early irregular contraction kind of phase.
Bless you.
You will see a variety of kind of ending dilation or when active labor starts. And your book doesn't even give like a set dilation, but usually between 4 to 6 centimeters is when most people will call active labor. We're really starting to talk about more 6 centimeters as active labor. We find that, like nationally, we're admitting patients, calling them active labor at 4 centimeters, and then they stall out. And then we have to do all the intervention. We have to break their water. We have to start Pitocin. We're not really waiting for them to get into that active phase. We know the more interventions we do, the more likely they are to end up in a C-section. So we're really starting to see if we can wait a little bit longer. Obviously, patient comfort is like our biggest priority. So if somebody comes in, they are 4 centimeters and they are just losing it. They are no longer coping with their contractions. We're gonna be more likely to just admit them, give them an epidural, and then get things going. Active phase is about 6 centimeters to about 8 centimeters. What is gonna determine if they are in active labor? There's not, contractions don't matter. I mean, they should be contracting every 2 to 3 minutes, but we don't actually care about contractions or how strong they are. The only way you know if they are in active labor is cervical change. I checked you and you're 4 centimeters, and 2 hours later I check you again and you're 5. You're considered active labor. So I will have patients in triage say, oh, my contractions aren't picking up on the monitor. Well, it's an external monitor and I cannot always, it's trying to read the top of your, or the contraction. So the top of your uterus is getting tight. They're external. So depending on the size of the patient and their position, we may not be able to pick up contractions. I always tell people, like, I say it a little nicer, but I really don't care how often you're contracting. The only thing that's gonna determine if you stay for labor or not is if your cervix is changing. If you're contracting every 2 minutes and you are 1 centimeter and I check you 2 hours later and you're still 1 centimeter, you are not in active labor, unfortunately. So, triage is like the only area of the hospital that pretty much they come in with an 11 out of 10 pain and we send them home with Tylenol. Because that's the only safe thing that they can have. With obviously other coping measures that they can do at home. Birthing ball, heat packs, hot bath, hot shower, all the things that you can do to try to help with the pain, but there's nothing we can give you like narcotic wise to help with the pain if you're not in labor. So then our transition phase is about 8 centimeters till our full dilation, and that's when our patients, without an epidural, kind of start to feel like they can't do this anymore, right? They say, I can't do this, I need an epidural right now, I don't wanna do this, I wanna go home, never mind, I'm not having a baby today. Like, sounds funny when you're not doing it, but like that's really their instinct is to like, this pain is so bad that my body just doesn't wanna do this anymore. So this is where the labor nurses really like come in and, or if they have a doula, come in and just stay with them, encourage them, you can do this, your body knows what to do, we'll get through this, that kind of thing. So then our second stage is our pushing. So from 10 centimeters to delivery is our second stage. Does anybody know how long the second stage typically lasts for a first time mom? And if your nurses educate your primes, how long they might be pushing? Yeah, 1 to 3 hours is typical for first time moms. Second time moms, usually less than an hour. Third time moms, usually they just spit that baby out. Though we did have one the other day that pushed for like an hour and a half with their third baby. Sometimes it's been a while since they delivered. Maybe it's been 10 years since they had their last baby, and this is a new dad, and so maybe it's a different size baby than what we had in the past. Ideally, the first and second baby are paving the way. But if your first and second baby are 6 and 7 pounds, and your third one is 9, they didn't so much pave the way. And then our third stage is from delivery of baby to delivery of the placenta. Ideally, this is less than 30 to 45 minutes, depending on the doctor. If it's longer than that, we're probably gonna go to the OR and do what's called a D&C, which is dilation and curettage, where they essentially scrape the side of the uterus to get that placenta out under general anesthesia. Or anybody see this semester them reach up and try to get the placenta? Yeah. So whole arm kind of goes up there. Ideally, they have an epidural still. If they don't, they're getting fentanyl. See if they can tolerate, and the doctor will go up and see if they can manually grab the placenta and separate it. And then the fourth stage is not really labor anymore, but it is placenta until you will see anywhere from 2 to 4 hours. So our recovery. That fourth stage is the most likely when they are going to have that hemorrhage, postpartum hemorrhage. Any questions on stages or phases? Not super hard concepts, just things you need to know.
Somebody get a picture of that already? Can I take a picture real quick?
Absolutely. Okay. You guys want to talk about fetal monitoring next, or do you want to talk about the 5 Ps of determining how your labor progresses? A lot of information there. Sorry. Okay. So has anybody heard of the 5 Ps of labor?
This is not pain and pallor and all that.
Nope.
Okay.
Okay, so we have power, passage, passenger, position,
is my first time hearing that.
Well, it's a good thing we're going through this stuff today.
Yes.
Okay, so what is power, do you think, when it comes to labor? What's gonna give us our power?
Uterus?
Yes, contractions. How strong are our contractions? It's gonna determine how well our labor progresses. And then when we get to the end, those last stages, our pushing effort is gonna be part of our power too. Have you guys seen really not great pushers? Yeah. So some people, especially with an epidural, it's kind of hard to get that sensation. You don't have that necessarily that pressure sensation where they can tell where to push. But you will have people pushing like their face, so their face gets tight, but nothing happens in their like vaginal area. Or they'll tense up their legs a lot and they'll like push against the nurses. They'll be pushing out with their legs instead of pushing in their bottom. So sometimes it takes a little bit, sometimes it takes a few hours to get that pushing effort in the correct place. So some people you will see push 4 or 5 hours, and that's simply because it probably took a couple hours to get the hang of pushing. Okay, so passage. What do you think passage might refer to? Yes, the birth passage. So maternal pelvis. Have you guys heard of cephalopelvic disproportion? Cephalopelvic disproportion. So our baby's head is cephalic. Consider it cephalic. Cephalopelvic disproportion. So our head, baby's head, and our pelvis do not fit together, right? Our head is too big, our pelvis is too small to fit. So these are the patients that end up in a section. These are,
It's too big.
head is too big or the pelvis is too small, however you want to look at it. Okay, what's our passenger? Baby. So there is quite a bit to the passenger. So I just said cephalic is head. If we're not cephalic, what may be another way we are facing?
Posterior?
Breech. Breech. I can never remember. Whatever. Okay, what's that mean? Butt. Butt first. Usually, can be the leg too, but we're facing the wrong direction, right? You can also have a shoulder presentation. We can have a face presentation. So that's when the face is trying to come out. The cervix cannot deliver that way. That face is not going to be able to fit through. So we're looking at fetal lie. fetal lie is longitudinal, so up and down, or transverse, side to side. So either cephalic or breech are both longitudinal. They can actually be transverse, so the baby can actually be like wrapped around your stomach. Also does not fit through the vagina that way either. Our baby's attitude. Which is our flexion or extension. So baby ideally head is flexed, so chin to their chest, so that they can better fit through the pelvis. If our baby's head is extended, it doesn't fit this way. So we need it to be flexed. We're trying to have the smallest part of the head come out first. So that's the back of the head. Versus if we're extended, then we have the whole head coming. So we want just the top versus the whole head. And then we talked about presentation. So cephalic, breech. The other thing we're feeling sutures. So you guys talked about in peds the diamond and the triangle, right?
Slightly.
When you're feeling the baby sutures, right? Where you have the triangle at the top and the triangle in the back, right? Where the sutures come together. So we're feeling that when we're checking their cervix. So you will find the sutures and you will follow the line to see if there's a triangle there, or if you're feeling the diamond or the triangle. And then we're gonna try to guess which way baby is facing. So if you feel in the cervix, you should be feeling the triangle up here. The diamond like in the middle. The baby is facing the right direction. So the back of the head is occiput is the back of the baby's head. That's what we're feeling for. And it is either anterior or posterior. So here's posterior is mom's back, right? And anterior is mom's front. So we want, you will hear OA or OP, occiput, anterior, occiput, posterior, and that is the way the baby is facing. So we want that back of the baby's head anterior.
Okay, so the sutures are the places where the cranial plates are meeting.
Mm-hmm.
And what did you call the fontanelles?
So there's a triangle fontanelle and there's a diamond.
But you used a different word. Or did you?
No.
Okay.
Nope.
Oh, maybe I'm thinking of suture.
So occiput is the back of the baby's head. So we're feeling for that triangle to feel where the back of the baby's head is. So if we want it to be face down, right? That's how you saw babies deliver, face down. If they are face up, they just don't fit through the pelvis correctly. They can deliver vaginally, OP, but it's going to take significantly longer to push. And the majority of first-time moms are not going to be able to push that baby out vaginally. So it's where the back of the baby's head is in relation to mom's pelvis. You can get into all kinds of complicated facing. I mean, they can be facing to the side. They can be facing to the other side. So it can be ROA, LOA, LOP, ROP. You guys don't need to know all that. But just terms that you may hear.
My first little girl, they said, was sunny side up.
Yes, so that is OP. in the layman's term, sunny side up. So the baby's face is pointed upwards, so we call it sunny side up. So this part is position. The position of our baby. And then our psyche, so our anxiety and our fear. So our psyche can actually sometimes prevent us from our labor progressing. So if our patient's too tense, constantly not breathing, their labor just doesn't always go as well. So you will see sometimes people want to do labor all natural. They get to 8 centimeters and they just stop changing. And it's hours and hours and hours. And then you finally say, okay, we've done everything we can. Our last thing that we can do before a C-section, because you can't have a baby at 8 centimeters, is to get an epidural. They get an epidural, they relax, 30 minutes later, they're fully dilated. Doesn't always prevent it. Sometimes people come in 8 centimeters and they do not want to deliver without an epidural, but their body just doesn't give them much choice. But our fear and our anxiety can definitely prevent our labor from progressing.
Do you ever have to send out like their partner? Like if they feel like they're contributing to the stress?
You do sometimes have to have a discussion with the partner. Like, you are actually not helping the situation right now. You are making the situation worse. You can't really kick them out unless they get aggressive, and then we call security and can escort them out. But usually that doesn't help mom when that happens, because then she's all concerned about him instead of what is happening. So unfortunately, there are definitely dads that are, oh, you don't need the epidural, you're fine. Till you are pushing a watermelon out of your vagina, or you do not get a say, right? So, questions about this? Does it kind of make sense?
I'm really glad you're teaching this.
Okay, so we go through, I don't want to run into peds. So we need to
She
do,
has class until 10. anyways.
okay, we do need to go through fetal monitoring.
I have a huge going on.
Okay,
Huge.
everybody good if I erase this? Okay. Fetal monitoring. I'm gonna go back over there, so you don't need to bring questions.
On the ATI about fetal monitoring, I was like, what?
Yeah, I had a question on the ATI about the cranial plates overlapping and whether that was like a problem or normal.
Yep, that's normal,
Like
so,
that's the cone?
Yep.
head? Okay.
so they override so they fit through the pelvis.
That's what I figured.
So you will feel overriding sutures still, sometimes right after the baby's born, and that's normal.
Okay.
Yeah, I just have a question about fetal monitoring.
And there was a lot we had to do all.
Okay, you guys have all seen the fetal monitor strips, right? At the hospital. These are like so old they're yellow. These are not mine. These were prior people's. Okay, so our fetal monitors, we need to know our baseline. So that's the average heart rate. And we're gonna do it in in fives. So we're not gonna say our baseline is 141. We're gonna say 140, 145, 150. And we are gonna look at it over a 10-minute period. And to be considered a baseline, we have to have 2 minutes uninterrupted. So we can't have like acceleration or decelerations or anything happen in like a 2-minute segment to really consider it a baseline. So I can pass this one around, but uninterrupted, sorry. So I'm gonna send this piece around and you will see the baseline is about 150 to 155. Let me see that.
Yeah.
You can see the little numbers.
Oh yeah. That's basically.
So 150, 155 would be here. So 150, 160, 170, 180. So each of the red is 10-minute boxes. So 155 would be right in the middle. So 150 over here, 155 over here.
Yeah.
See the 150 here. So if it's right between the 150 and the 160 like it is here, we would consider it like 155.
This is 1 minute. Period. One. This is 10-minute. Period. And this would be an acceleration. Sorry, I'm just being nosy.
You're fine. Okay, so what's our normal heart rate for baby? So 110, 120, 160 is normal. Less than 110 is going to be considered bradycardia. You guys are familiar with these terms? Greater than 160, tachycardia. Right? What do you think are some things that might cause baby to be tachycardic? Not really, it doesn't really affect baby for anxiety. But we talked about fever. Infection, yeah. Dehydration can actually. Acute blood loss in the fetus. Cocaine.
Oh, cocaine can cause. Okay.
Hey, are you ready for them?
I'll let you finish.
Yoo-hoo!
Yum.
Help yourself.
Oh, yeah, I need to. No, I will back out. I just wondered, where you were. That answers my question.
Just fetal monitoring. It won't take very long.
I'll leave it on. I'll get out.
You're welcome to stay. Okay. What's going to cause bradycardia? Meds can cause both.
General anesthesia.
Yes. General anesthesia, so. But we We're not gonna be really monitoring baby, but we know that causes bradycardia. There's different cardiac issues that can cause it in babies. And what's called interrupted fetal oxygen pathway. So what are all the things that maybe could cause that? Are uterine ruptures, are placental abruptions, anything that's going to interrupt the fetal oxygen pathway. One thing we will talk about, or I will mention real quick, is umbilical cord prolapse. What do you think an umbilical cord prolapse is?
When it comes out first.
Yes, so the umbilical cord is out before the baby. So they go in, they break mom's water, or mom comes in with her water already broken, and baby's head is still so high that it's not plugging that hole, so the cord comes through first.
Wait, what's it called again?
Umbilical cord prolapse. So the problem is the umbilical cord gives baby oxygen, and once the umbilical cord comes through first, then the baby's head is putting pressure on the umbilical cord and cutting off the oxygen. So it isn't a medical emergency. The big thing you need to know is your job, if you are the nurse, is to go in to the cervix and apply pressure to that head. So push it up so it's off the cord. And that is where you will live until the C-section occurs. So you get to ride on the bed, you get to be moved to the OR bed, your hand is in the cervix the whole time, pushing baby's head up. So that's your first priority. If you get that question on ATI, that is your first priority. Not calling the doctor. You're gonna obviously push your emergency button, but everybody else is gonna be prepping your patient, calling your doctor, all of that stuff. Your job is to just ride in the bed, checking a cervix the whole time, really pushing baby's head up. Okay, so we talked about baseline. We have our baseline. And then we have our variability. So what's our variability?
Range goes
Yep.
up and down.
Yep, so where our baseline is occurring, how much does our baby's heart rate change from baseline? So you have minimal variability, which is less than 5 beats per minute. So you will see kind of at the beginning of this strip here, I can show again, but there's very little change from 150. Very little change, less than 5. So this is minimal variability. Less than 5 beats. We're not really getting much change. We're pretty much straight around the 150. And then you have moderate, which is 6 to 25 beats per minute. That's the second half where we see a little bit more change from baseline. This is where we want to live. This means our baby is well oxygenated. Marked is greater than 25 beats per minute. You really probably won't ever hear that term, but, and then you have absent, which is no variability. That is our like flat line. And this is something you never want to see as a labor nurse is absent variability. That means your baby is compromised. And we need to get that baby out as soon as possible. Okay. In terms of decels and excels, you will see the term field job. So you have a variable decel, you have accelerations, early decels, and late decels. So a variable is you have your baseline and then it's a quick down and a quick back up. Doesn't matter where the contraction is. They can happen during a contraction, after a contraction. Quick down, quick back up. Less than 30 seconds from the onset to what's called the nadir, which is the lowest point of the deceleration. So this is less than 30 seconds. So quick down, quick back up. What does that mean? Cord compression. So our nuchal cords around, when they're around the neck, cause that. It can be that the umbilical cord is between the head and the uterus. So every time it contracts, it compresses the umbilical cord. So essentially, just a quick squeeze, and then whatever is causing it usually lets up, and it's a quick back up. These can be kind of little ones, they can be deep ones, depending on the severity and how baby recovers afterwards is going to determine if we're doing okay. Feel is spelled differently. I was like, why is that? Weird. Sorry. If I knew how to spell. I'm like, that doesn't work with that. Okay. Sorry. Okay. So our early deceleration, we have our contractions. And we know that the frequency of our contraction is from the start of one to the start of next. Right? Our duration is the amount of time our contractions last. So we are going along, and then we have a deceleration during the contraction. Whoop. And this time, our onset to nadir is greater than or equal to 30 seconds. And how you know it's an early is the bottom of the deceleration, the nadir, lines up with the peak of your contraction. So early and late decelerations have to do with our contractions. So again, the lowest point of our decel lines up with the highest point of our contraction. Early deceleration means head compression. So essentially that contraction happens and their head is getting squeezed, causes a vagal reaction and the baby drops their heart rate. The contraction ends, the squeeze stops, and their heart rate recovers.
Lowest part of heart rate is highest part of contraction.
Yep. So these we're fine with. These are the things that The nurse will be standing at the desk and you'll hear him say, "Oh, I wonder if your patient's complete." That's because we start having these early decelerations. Your accelerations are obviously an acceleration in the baby's heart rate. So if our baseline is 135, it needs to go up by at least 15 beats. So we need to hit at least 150 at the peak. 15 beats times 15 seconds. 15 by 15. So this whole thing needs to last at least 15 seconds. Go up by 15 beats and last for 15 seconds to be considered an acceleration. 15 by 15. You guys don't need to know, but our pretermers are 10 by 10, but I don't think that will be on your ATI. I wouldn't think they'd get that into it. And that means your baby is well oxygenated. You have a happy baby. And then our last deceleration, like I said, has to do with our contractions again. This time, we start usually around the time the contraction is part of the way done. But this time, it's again 30 seconds, onset to nadir. But this time, the lowest point is after the contraction. So this one is at peak of contraction. This one is after contraction. CTX is contraction, if you haven't seen that. And what's that mean? Placental insufficiency. So your baby is compromised. This contraction has stressed your baby out so much that it's causing a deceleration in their heart rate. So we don't like to see these. What do we do if we see these? Position changes, increase fluid, turn off our Pitocin, throw on some oxygen on mom. Probably things you guys saw when you were on the floor. So late is the one we're super concerned about. Variable, depending on how severe and how well your baby recovers. If you start to have really deep variable decelerations and you start to hit the minimal variability, we're no longer having accelerations. We know that our baby's starting to not tolerate labor. But our lates are our biggest concern.
So the peak heart rate is after the contraction?
The lowest point.
Lowest point's after the
Yep.
contraction.
So our early is at the peak of the contraction, our late is after the contraction. Well, got through part of it.
Thank you so much.
Yes.